Welcome back to the second session of our very exciting conference. This one is called National Struggles for Health Equity and Universal Health Coverage, Political Drivers. So we're continuing the conversation on politics. My name is Jashodhara Dasgupta and I'm from India. I was very privileged to be part of the Lancet University of Oslo Commission that Olapeta has just spoken about. And I'm also very honored to chair this panel with a range of speakers and a range of topics that are going to be really exciting in terms of deepening our debate around the political drivers for universal health coverage, which is being announced as the formula in the SDGs era. So when we look at the slogan, Health for All, very relevant because of the recent kind of commemoration at Astana, and look at what it has become within the framework of universal health coverage, it's very interesting to move to Sri Lanka and listen to Ramya. Ramya is a lecturer at the Faculty of Medicine in the University of Jaffna, and she has done a PhD from the University of Toronto. And Ramya will be talking about, quote unquote, free health and the politics of universal health coverage in Sri Lanka. Ramya.
Hi, so I want to start off by saying that I pride my location in the global south. I'm from Sri Lanka and I returned there after my PhD. And I want to also acknowledge the colonial history from which many of the terms I draw upon that continue to be used in global health, and I acknowledge them, their colonial history before I use them. So I will refer to things like maternal and child health and non-communicable diseases and universal health coverage, which I think come from that kind of place. So apart from the undemocratic power grab that took place 3 days ago in Sri Lanka, Sri Lanka has recently been in the spotlight for various health achievements. And among them, universal health coverage is one. In fact, this year, the World Health Organization recognized Sri Lanka's gains by holding World Health Day in Colombo. So my talk will briefly address 4 questions. First, what is the historical legacy of these accomplishments, like the health achievements in Sri Lanka? What does healthcare access look like now in Sri Lanka? And what reforms in the guise of UHC are in the pipeline? And what tensions are there around implementing UHC reforms in Sri Lanka? So what is its historical legacy, which is often left out in contemporary discussions on Sri Lanka? So the foundations of the public healthcare system were indeed laid in the 19th century under British colonialism. So, however, also left out of contemporary discussions is that rural expansion of healthcare took place in the 1930s, still when Sri Lanka was under colonialism, but after a malaria epidemic, when the left movement got involved. And by that time, so Sri Lanka had universal franchise by 1931. So capitalizing on it, the anti-colonial and left movement got involved in relief efforts and drove state investment in healthcare. So by 1948, when we got independence, the allopathic system comprised about 250 institutions. So there is an indigenous medical service, but I will not be talking about that. I'll be happy to discuss it with you later. So arguably, more important in terms of Sri Lanka's health achievements is the series of social policies that were adopted in the late colonial period. So there were food subsidies that were in effect since the 1940s that came into place due to food scarcity during the Second World War, but these continued to be in place till the 1970s. Then in 1945, the government adopted free education policy, which granted universal primary and secondary education. So the free health policy was adopted in the immediate aftermath of independence, and this was in 1951, and it removed all user fees in the public system. So these policies would actually shape claims on the state in subsequent years, and I think that is a crucial thing to remember about why universal health coverage, or whatever is left of it, still remains in Sri Lanka, because the public really support free healthcare. So by the 1970s, of course, as terms of trade became unfavorable, which started in the 1950s, and by the 1970s, there was an economic crisis, like many third world countries. And so in 1971, there were some user fees that were introduced, but then a subsequent government that came in that adopted an expansive regime of economic liberalization took away those user fees as a populist gesture. So still we have free healthcare, which covers drugs and services and consultations, but after that there was incentivized private sector expansion that really, I believe, has messed up our healthcare system. So what does access look like now? So today the public healthcare system covers about 50% of outpatient services, 90% of inpatient admissions, which is why catastrophic and impoverishing health expenditures are quite low, and near all preventive services. So the system is spread across the urban and rural areas, and although tertiary care tends to be concentrated in urban settings, still we have a system that is quite good, I think. So this system is funded by it's a tax-based health financing system. I mean the public healthcare system, obviously, but unfortunately through a large share of it is through a regressive indirect taxation. So free health essentially means that users may walk into any public sector clinic or healthcare in any part of the country and demand service without proof of identity, citizenship, or any other status. All services, as I said before, are free at the point of use. However, given crippling shortages in medical supplies and services, result of inadequate public investment, about half of outpatient visits take place in the private sector. So what's left of the public healthcare system, I would say, works very well for infectious disease control and maternal and child health, for which it was originally set up. A countrywide surveillance system staffed by locally trained public health teams has been critical to the control and elimination of some communicable diseases. As well, Sri Lanka's public sector also shows impressive results in relation to maternal and child health. A community-based MCH service links up primary care centers across the country with secondary and tertiary level obstetric services. However, a gap exists in the area of chronic non-communicable diseases, and this is all the more important with an aging population and the absence of community-based elder care. So comprehensive care for NCDs is largely confined to tertiary care centers, which are overcrowded owing to underdeveloped primary care centers and the lack of an effective referral system. So these primary care centers have not been developed precisely because of what an earlier speaker spoke of, how funding is being channeled into tertiary care. So wait times are long, consultation times short, and there is little continuity of care. So this situation is complicated by unregulated private practice. The private sector relies on the state sector for a physician workforce. Many public sector doctors work after hours in the private sector, catering to the excess demand for outpatient care. So except in the lowest wealth quintile, most access much of their outpatient care in the private sector, contributing to a large share of out-of-pocket spending, a major concern for policymakers. So what reforms are in the pipeline in terms of UHC? So a strong system of integrated primary care is required right now. We don't have it, especially for the curative sector. So it is this gap that is primarily targeted by proposed UHC reforms in Sri Lanka. Earlier this month, the Ministry of Health released its new policy on healthcare delivery for universal health coverage, which includes expansive reforms for the health sector. The initiative is led by the Ministry of Health, with funding from World Bank and Asian Development Bank. The policy was developed through a top-down stakeholder consultation process with very minimal public engagement. The UHC policy encompasses 13 strategies, including reorganization of primary healthcare services through shared care clusters, which refer to units in which specialist care centers function as the apex referral center to surrounding primary care centers. The policy includes plans for human resource strengthening, including a family doctor per 5,000 population, access to all essential medicines and diagnostics, and equitable distribution of specialist care through an essential services package. So all the details of this are actually available on the Ministry of Health website under publications. As well as an improved health information system, citizen engagement and empowerment, and last, effective engagement with the private sector. So the Ministry of Health expects to contract in private sector primary care providers to ensure free healthcare where there is a deficit of public services. These reforms, if implemented, will create formal partnerships with the private sector. While this may not seem out of the ordinary, it is in fact an unprecedented move in terms of health sector development in Sri Lanka. So what are the current political tensions around implementing these reforms? First and foremost, I would argue that free health still holds wide public appeal, owing to possible electoral repercussions and in practical terms, actually, the low cost associated with the current system, politicians and policymakers seem reluctant to implement drastic health reforms, especially in terms of healthcare financing. I'm talking about the public system at the moment. So in addition, the medical establishment too supports free healthcare within a tiered public-private healthcare system for obvious reasons, because they stand to lose if the private sector is shrunk. Thus, reforms that advance freely accessible healthcare are likely to still find support all around at national level. However, this may change soon as elite and middle classes increasingly opt out to the private sector. However, support for free healthcare is fraught in the context of economic crisis. So where will the funds come from? The government is desperately looking for avenues for economic growth, and the health sector holds potential in this respect. At this time, the focus is expanding commercial hospitals, the health insurance industry, and medical tourism, heralding rapid private sector expansion in coming years. So this brings to my second influence, of course, the healthcare industry. A fast-growing private health sector flourishes in urban settings. In 2015, over half, 54% of health spending came from private sources. Of this, 85% was paid out of pocket. But actually, this gives a wrong impression of what healthcare actually looks like, because the private sector healthcare services are highly overpriced, so it does not really reflect the volume of services being provided. So private sector expansion is subsidized by the state. Last year's budget included a health insurance scheme to cover the private healthcare expenses for all school children, which has since been implemented. The government also provides massive subsidies to the private healthcare industry through the Board of Investment, including tax holidays, concessionary rates on corporate income tax, import duty exemptions, and concessionary lease terms on state lands. However, because private healthcare is financed out of pocket, its expansion has been limited to urban areas where wealth is concentrated. Gradually expanding health insurance coverage, however, would support private sector expansion and could in parallel weaken the public healthcare system, for example, by brain drain of healthcare professionals from public to private. Despite its implications, private health sector expansion is both ideologically and financially supported by IMF and World Bank, a third influence. So IFIs have intervened in the country's economy since the 1950s. The IMF has repeated its mantra of cuts to public spending. Most recently, a 2016 IMF agreement was followed by cuts to the health budget. So the World Bank has pushed its privatization agenda. In fact, in the current health sector development project that's being implemented, and in its project appraisal report says it will be, I quote, a significant step towards a more public-private partnership enabling environment. So a fourth influence, I would argue, on these UHC reforms is the Physicians' Trade Union. So in last year, they actually brought down the only existing private medical higher education institution in the country through strike action supported by the students' movement. However, it was not based on any opposition, any radical opposition to privatization, but largely the struggle was framed in terms of quality. So they have remained silent on private healthcare regulation, presumably because a large section of its membership engages in unregulated dual practice. So for this reform to strengthen primary healthcare to work, there has to be regulation of dual practice, because right now most patients enter the public hospitals through private practice so that they can circumvent the queues and wait lists and things like that. So implementing an effective referral system will definitely see opposition from the Physicians' Trade Union. And finally, so the framing of universal health coverage. So definitions of UHC at the global level skirt vexing questions of whether healthcare financing, delivery, purchasing, and provision should be public or private. In fact, UHC reforms recommended by dominant global health agencies hold up a mixed public-private model, as Emmanuel talked about a little while ago. So Sri Lanka's primary healthcare strengthening project that is under implementation, interestingly, draws on UHC as a... Oh, okay, sorry, I'm over time. I thought you'd be telling me in 1 minute, just 30 seconds. UHC reforms are needed to address gaps in primary healthcare, but questions remain about the feasibility of this particular direction of health reform. So, so UHC as currently operationalized may shift the focus of reform in Sri Lanka from one that supports publicly financed and delivered free healthcare to one that endorses an integrated mixed public-private healthcare system. So I think that's a really important thing that we in the conference can really emphasize, that this talk of mixed public-private is really not helpful. So, in terms of Sri Lanka, people just seem to forget that Sri Lanka's health achievements are rooted in this history of equity-oriented policies that went far beyond the health sector, and of course, that remained in public hands. The healthcare system remained in public hands, at least the one that's functioning right now. So thank you.
Thanks very much, Ramya. I think it's always good to be reminded about the kind of progressive and anti-colonial movements that initially moved the agenda of people's health in people's hands, and to be mindful of the various forces and influences that are changing it into public money in private hands. So with that, I'd like to invite our third speaker, Cristiani Vieira Machado from Brazil. She's the coordinator of the Public Health Graduate Program at Fiocruz, and she will be speaking on inequalities and political struggles for a universal health system in Brazil. Cristiani.
I don't need this one. So, good morning. Thank you very much for the invitation. I'm very, very glad to be here in such an important conference and to share a little bit about Brazilian experience in building a universal health system. Okay. First of all, it's important to say that Brazil is a very big country with more than 200 million inhabitants, and it's widely known as one of the most unequal countries in the world. The focus of my presentation will be the struggle to build a universal health system in Brazil from the mid-80s to the current date, considering the relations between international and national contexts, the nature of democracy and of governmental priorities in the economic and social areas, and the interaction between agendas and actors involved in health policies. Just briefly, it's important to say that until the 70s, health policy in Brazil was marked by a dualism. On the one hand, we had public health programs, mainly directed to the control of specific infectious diseases. And on the other hand, we had social insurance for workers, for formal workers in the urban areas. And also we had, since the 60s, incentives to the private sector in providing services in the country. And in the late 70s, this system was very criticized because it was segmented, fragmented, limited, unequal, ineffective, and also this expanding private sector wasn't able to meet people's needs. And so alternative proposals and local experiences were implemented. And then in the 80s, we had a democratization process after more than 20 years of military dictatorship. And we can identify 3 moments since then, since the mid-80s, in what regards the relations between democracy, political struggles, and health policy. I will talk very briefly about each of them. The first period is the democratic transition and health reform from 85 to 89. We were under an economic crisis and a democratization process. And unlike other Latin American countries, Brazil did not implement neoliberal reforms in the 80s. Later, the country would implement them. And so, in this context of democratization, there was a broad coalition between public health actors, academics, social movements, and legislators to propose a broad reform agenda. And Brazil was able to enact a new constitution in 1988 that expanded social rights, adopted a broad social security perspective comprising pensions, social welfare, and health, and recognized health as a right of citizenship, and also created the unified health system, the SUS, which should be public, universal, and comprehensive, and tax-funded. And the second moment is what I'm calling the democratic period from 90 to 2015, in which we had political struggles over SUS implementation. Different agendas and actors influenced health policy during this period. The first was the health reform agenda, the SUS implementation, supported by public health organizations and academics, health authorities and bureaucracy at the 3 governmental levels, some public attorneys, health professionals in the public sector, and participatory health councils, and also some social movements. The second agenda was the market-oriented agenda supported by economic authorities, several groups in the National Congress, the health industry, both national and international health companies, and also some international organizations as the World Bank and the IMF. And there were also other agendas, like, the doctors and the unions. They had their own agendas directed to their group interests. They are not supporting neither completely SUS or the private sector. It depends. They're not homogeneous. And the third moment dates from 2016 to the current day. Now, I'm calling it the moment of political crisis, democratic instability, and threats to the SUS. It begins with the impeachment of President Dilma Rousseff, in 2016. Since she was re-elected, she was a Worker Party's president. Since she was re-elected in 2014, she wasn't able to govern properly because of strong opposition. There was this broad anti-Rousseff coalition involving Congress, judiciary, the media, economic alliance. And so her impeachment was mainly a political process, a very complicated one. We can talk about that later. And so, after she was impeached, her vice president, Temer, took office and implemented neoliberal reforms, austerity reforms that were very striking and fast. For example, someone has mentioned, the constitutional amendment which freezes social expenditures for 20 years. Temer's first Minister of Health was a guy with ties to private insurance companies whose main proposal was to expand popular or low-cost private health plans for low-income people. And last Sunday, we elected a new president, Jair Bolsonaro, who is a former military and extreme right congressman. So prospects for social policies and for the universal health system are not very good at this moment. Just some data to illustrate. Here you can see the coverage of family health strategy. It's our main primary healthcare strategy. It has increased a lot during the SUS implementation, and its coverage is higher in the poorest areas of the country, so it's important to promote equity. There is a slight decrease in the last 2 years, since 2016. And here you can see infant mortality rates. During 20 years, they decreased in all Brazilian regions. They are partially due to general social improvements and partially due to health improvements, health services improvements as well. And you can see that at the end of the period in 2016, we had an increase in infant mortality for the first time in more than 30 years. People are worried about that, okay, a slight increase. And here you can see health expenditures. They have expanded. They were expanded in Brazil, total health expenditures, but during the whole period, public expenditure, which is the blue bar, has never reached 4% of the gross domestic product and has never reached 50% of total expenditures, which is too low for a universal public system, okay? And the middle bar, the green bar, is the private expenditures with private health plans, and the upper bar is out-of-pocket expenditures that have decreased. In the coverage of private health plans, we have an important public system, but also an important private sector, private insurance sector, and its coverage increased parallel to the public system in all Brazilian regions, especially in the richest ones. And in the last 2 years, we had a decrease because of the economic crisis and the rising of unemployment rates in the country. It covers altogether around 24-25% of the Brazilian population. These people can use as well the public system because it's universal. So my final remarks. Democracy has been essential to ensure universal right to health care, institutional reforms and social participation, expansion of comprehensive policies and of public service coverage, improvements in health outcomes, and some reduction in health inequalities throughout the country. Nevertheless, insufficient public funding and the strength of the private sector have been the main obstacles to reduce health inequalities. There were increases in private provision in healthcare subsidized by the state parallel to the expansion of public services. International and national health companies, they have adopted recently new business strategies and lobbying to expand their market and profits. And there are still persistent regional and social inequalities between regions and social groups. So our current prospects are not very good, but I would say, as you say in Brazil, good fight goes on, ou a luta continua. Thank you very much.
Thanks very much, Cristiani. It's again a very sobering story and very worrying recent processes within the country. So the final speaker in this exciting panel is Ruth, and Ruth is an associate professor of medical anthropology at the University of Oslo. And Ruth will be speaking to us about universal health coverage and the public good, which are her critical perspectives from work in Kenya. Ruth. Would you like to use this? Yes, I think so.
Thanks so much. So many people would argue that universal health coverage and global health should be a way of pursuing social justice. Recent moves towards universal health coverage seem to take up this challenge. And in my presentation, I want to look at kind of question what forms of justice are being pursued in universal health coverage with a focus on Kenya's move towards UHC. UHC is presented as a policy that pursues social justice, as we've heard from many speakers today, but both in the WHO's pronouncements and also in the ways that individual countries are taking it up as a major goal of development. But if we look at implementation of UHC, it's much more about technical pragmatism, and market moralities are extremely prevalent, as we've also heard this morning. Indeed, may be dominant in the pursuit of UHC, for example, in the preference for private-public partnerships. So how does this rhetoric of social justice and solidarity and obligation and so on sit with the dominance of the market as a means of pursuing UHC? And what are the implications for the kinds of UHC that's being pursued? And I want to take a look at Kenya as an example of how the Kenyan government's pursuing UHC through a mixture of appeals to the public good and to solidarity, and through reforms of state institutions like the National Hospital Insurance Fund, which is the National Health Insurance Fund. Also through partnerships between private for-profit institutions and also non-profit institutions and companies and corporations. I'm also interested in how these issues are being debated, not only globally, but also in particular historical and social context. For example, in Kenya, there's a very vibrant public sphere, very vibrant kind of, a lot of debate in the Kenyan media and in the social media. So UHC is often described as the fulfillment of a social contract between the government or the state and its citizens. And this social contract has been, if you look at sort of histories of many African states, it's been noticeably absent in many African states in the past, working as they are often within the constraints of an international, global economic and political order. Moves towards UHC raise questions of citizenship. And this, I think, should lead to questions like how are citizens voicing their concerns and in relation to their states, and how governments, on the other hand, are kind of using arguments about national solidarity and the public good. Before I delve into the Kenyan context, I want to say a little bit about why I'm presenting on this. I've been doing research in Kenya as an anthropologist over the past 20 years, and I'm now leading a project on universal health coverage and the public good in Africa, which is a group of anthropologists and historians, some of whom are here, the project team, and we've just started, so I'm going to be raising more questions than I'm answering in this presentation. There's a lot of research going on how UHC is being implemented in many countries. This is not our primary focus. Our focus is more on questions like how UHC is mobilizing publics, about notions and practices of citizenship, about forms of governance, and about struggles around public health care in the context of this increasing privatization, which is going on in many African countries, and Kenya being very much at the forefront of this. Yeah, so UHC has been moving up the policy agenda in the face of rising evidence that structural adjustment policies of the past 30 years have had a very detrimental effect on poverty. And also in relation to the limited success of global health initiatives, which have been very successful in their own terms, in terms of numbers of bed nets distributed or numbers on ARVs, but often reinforce fragmentation and inequality. And in Kenya, in Kenya, there's been a lot of public discussion about this, as I've said, in the media, also including social media, but also in sort of public debates. And the debates about UHC and the kind of rise of UHC as a policy agenda is really coming in Kenya on the heels of a lot of public anger about the state of the public healthcare system. So from December 2016 until many months into 2017, the public healthcare system was absolutely paralyzed by strikes by health workers. First doctors strikes and then nurses strikes. And there were many, many months in which public hospitals and health facilities in Kenya were empty of doctors, empty of nurses, and empty of patients. And during this time, if you did not have health insurance, you had to go home, or you could try to use traditional medicine. But it was a complete disaster, and it indicates, I think, a really important point that amidst all these debates about universal health coverage, there's an ongoing austerity that is it's still very much there. It's not that structural adjustment is over. Ongoing austerity in which these public health systems are struggling to work. And it's interesting in relation to this talk about Sri Lanka just now that, well, these doctors were not actually striking about issues like privatization either. They were striking about quality of care, about conditions of work and about payment, but in the debates that arose around this strike, the question of privatization and the increasing corporate investment in Kenya's very lucrative private healthcare system, this became a big issue that many of the doctors' union people were involved in this discussion. So it really came up. So in this context, just look to so there's some pictures from recent Kenyan newspapers about these kinds of issues. And I'll come back to this briefly at the end. In this context, just to look briefly at Kenya's moves towards UHC, recent moves, I mean, there's this long history. This paper we just heard had a very nice history about Brazil's and also the Sri Lankan kind of past, and one could do that for Kenya too. I'm not doing that here, partly because tomorrow or later on we were supposed to hear from Edwin Baraza, who's a very prominent health economist in Kenya, but we've just heard that his visa has been denied. So I was hoping, to have a dialogue with Edwin later on. But anyway, I'm just going to focus then on the recent moves, and these are, looking positive, like they abolished user fees in 2013 at public primary healthcare facilities. They introduced this free maternity care, so this is what many African countries are starting off with maternity care in relation to UHC. They've reformed the National Health Insurance Fund, the National Hospital Insurance Fund, extending it from inpatient services to outpatient and also into the informal sector. However, as Edwin Baraza has been doing a lot of research on, his conclusion is this National Health Insurance Fund is regressive, it's not pro-poor. There's also moves towards social protection, often funded by World Bank, Rockefeller Foundation, Gates, and so on. Not Gates in the social protection, but I mean, a lot of this is actually being funded by outside donors. So the question of sustainability rises. And then lastly, just now in the last couple of months, there's been a big drive to roll out UHC in 4 pilot counties in Kenya. So Kenya has a devolved healthcare system now where healthcare is being devolved to the counties since the change in the constitution in 2010. And so right now we're seeing this big rollout of getting more people insured, rolling out health insurance. And this is something we're very interested in this project, to look at, so what is actually happening here and what kind of health insurance is being rolled out? And what actually is this health insurance? Because although it's working in partnership with the National Hospital Insurance Fund, which is a parastatal, it's doing this also through different insurance companies, some of which are for-profit and some of which are not for-profit, and there's a lot of blurring between what's for-profit and what's not for-profit here. So it's an area that is changing. Kenya is seen as this kind of also on the forefront of experiments in digital health and in mobile health. So a lot of these extensions of health insurance actually kind of taking place in the area of health insurance companies working with digital platforms, because Kenya has a very high mobile phone usage, a lot of huge mobile money banking, mobile money transfers, and so health insurance is seen, this can happen in this area. So we need to really keep an eye on what's going on there. Right, so what are the political ambitions surrounding UHC? So, it's often seen as this new approach and new ways of thinking about poverty and redistribution, about health and development, and about the state and citizenship. Yet it's surrounded by contradictions, which we've heard today from other speakers. It involves struggles to formalize social protection, extend health insurance. While healthcare remains extremely fragmented, it also remains an extremely profitable market, especially in many African countries where you have this rise of the middle class. The middle class is seen as this very profitable market for health insurance, but also for health services. And then many forms of extending health insurance increase fragmentation and are regressive. So the question is, whether UHC also in these contexts is a sticking plaster solution, which maintains the status quo, while offering a minimalist biopolitics of care. So UHC is often likened to alma ata, or kind of even regarded as some kind of return to alma ata. But as we heard from Anna Emmanuel Byrne, the question of what's universal, the question of what is coverage, here we need to really think about these issues. I don't really have time to go into these details about the health insurance landscape in Kenya, and if you're looking at this kind of rollout, how it's been rolled out. But these are health insurers that we're looking at in our project. Microinsure is one of them. Microinsure has received kind of seed funding from the Gates Foundation, but it's a for-profit company, and it kind of uses this language of transforming insurance in emerging markets, and the poor are often seen as this emerging market. So what does it mean when you have for-profit insurance companies using the umbrella of universal health coverage to kind of present themselves as kind of providing a social good that is giving insurance to previously uninsured population, providing some kind of financial protection? What does that mean when they're for-profit, at the same time they're explicitly they're not trying to hide the for-profit thing either. I mean, this is very different from corporate social responsibility, where you had a company that then kind of had a kind of corporate social responsibility program to ease its self-image. This is a situation where these companies are up front. You can do a social good while pursuing profit. What does that mean when it comes to if you're actually trying to kind of enroll poorer populations into some form of social protection? So microinsure is very interesting regarding that. And then Pharma accesses this a non-for-profit company, an NGO actually, which is also very much involved in the digital platform, mobile health platform in Kenya, and it has this MTIBA, which is something to look at too, because MTIBA is actually a health wallet. It's not insurance. It's not about pooling risk. It's actually getting people to save small amounts of money, which are explicitly put aside for health. But then you only get what you, although at the moment, because it's trying to enroll more people into it, MTIBA does kind of, if you put in 50 US cents, then you get 50 US cents from MTIBA as a way of getting people to enroll in this. But the fact is that in the end, then you only have $1 in which to spend on health, and it has kind of agreements with private facilities, small-scale private facilities in Kenya. So what's happening with MTIBA is also very interesting. So I don't have time to go further into this, but I'm really happy to talk about it with anyone who's interested afterwards, and in the breaks and so on. Hang on. So yeah, let's just to kind of wrap up then. Well, Many people see global health as a forum for pursuing social justice, but we can also see that market justice approaches are very dominant in universal health coverage, where a market justice approach kind of minimalizes by forms of politics and employs an economistic rationale. It's very unclear where UHC is positioned, actually, in relation to these frameworks. And of course, they're rather schematic, the social justice and the market justice. So there's kind of a lot of ambiguity regarding what universal health coverage is doing. But what is clear is that there are a lot of contradictions. It can serve very different political and social agendas. It appears to return to some key mid-20th century values concerning health for all and push for greater social protection in the global south. At the same time, this is happening when welfare and social protection is being slashed worldwide. So whether it's truly transformative and what the political ambition surrounding UHC is something we need to really think about. But I'm very interested in this project. We're very interested in looking at how this has really been pursued in different African countries, and also to look at universal health coverage not only, as a translation of a global policy to national and local context, but really look kind of attending to how it gains traction in particular national contexts, in particular, which have particular histories, regarding states and citizens and the relations between the private and the public. So just to end then, I just want to just point towards this research program that we're really just starting now. Some of the project team members are here, and these are the questions that we have in this research that we're pursuing. So we'll be very interested in talking to some of you about these research objectives and our methodologies, and keep an eye on what we're doing in the future. Thank you very much.
Thanks very much, Ruth, and it's a real pity that Edwin is not here, but I think you have really pointed out for us the kind of smoke and mirrors aspect of universal health coverage, where we are kind of blurring the for-profit with the idea of public good, and one is never quite sure whether this kind of wholehearted global endorsement of the concept of universal health coverage is really to expand space for health markets to flourish, or whether it truly is fulfilling the compact, the state-citizen compact of providing the kind of social protection we had thought of. So friends, we've had a very stellar panel, and they have brought out some of the ups and downs in the national struggles for health equity and universal health coverage. And I'm just going to take a couple of minutes to just share what I'm taking away from this. And this also resonates with our experience in India. In 2011, I was part of a high-level expert group set up by the Prime Minister to prepare a roadmap for universal health coverage in India. And the irony is that even though we had the complete support, and I can see Rob nodding here because he was also quite involved in advising our committee. But despite having the highest political backing, somehow health could not be made into a political agenda in the elections of 2014. And currently, if any of you are following the nightmare trajectory of what is happening in India, we have this completely reductionist package of what is being called as the Prime Minister's victory. It's actually, in India, the acronym actually means the Prime Minister's victory. It's PMJ. J means victory. So that's the, the Ayushman Bharat scheme that's being brought out. And I just want to flag a couple of things that I kind of resonated with my experience when the speakers were sharing. One, of course, is the whole the tax landscape and what kind of finances are actually made available for public good purposes, such as healthcare, as opposed to finances for other things like military spending and so on. And also how the issue of low budgets and the consequent starving and decimation of the public health systems and the active promotion and incentives to private healthcare providers and players like insurance companies ends up in creating a landscape where people begin to criticize the public health system and the middle classes gradually opt for a private health system. And so you then have a poor health system for the poor, which just goes from bad to worse, and then it sounds absolutely okay when the government says, okay, we are going to use public money to contract in private providers. I think within India, what has been the big struggle for us is the complete lack of political will in actually ensuring any meaningful regulation of the private sector, while at the same time providing them with incentives and concessions. And then we finally come down to these very reductionist packages of what people are supposed to need healthcare support for. It was interesting listening to Sri Lanka. Oh, how the mighty have fallen. In South Asia, we always looked at Sri Lanka as this, glowing example of public healthcare. And India, we were always so embarrassed. And it was really sad to hear from you, Ramya. And so there are these reductionist packages. In India, it is only for inpatient care. And outpatient care happens to be, including diagnostics and medicines, happens to be about 70 to 80% of what out-of-pocket expenditure is for. So it's actually not going to change anything compared, and then that is substantiated by the massive underfunding. So what's the way forward? And I think we've heard, it's not all doom and gloom. I think we've heard some very encouraging kind of historical references to how people's movements and, public dissatisfaction and the kind of contextual realities within, the country's political trajectory have actually led governments to prioritize social security and social protection and rights for the poor. So I think we need to map out our landscapes. We need to look at various associations and platforms that can come together. And then just to echo what David said earlier, we need to promote social solidarity in action. And I think as the academia, we need to ally much more strongly with the people's movements, with the civil society organizations that are actually trying to make health a reality. So with those comments, I'd like to invite all our speakers back here, and we will open the floor for your questions. So, and Emmanuel, Ruth, Ramya, Cristiani. So all of you have a mic. You don't have a mic, so you can use this one. Yeah. You don't have a mic either. Yeah. Okay. Yeah. Okay. So the floor is open. Right. And Rob, yes. Okay. So why don't we have the mic here? Do we have a mic going around? So one here. Yeah. Water. Thank you. Yeah.
Thank you. My name is Salima from Uganda. Just to thank the panel, and I really identify with many of the things that you've raised. So just curious to know from your experiences in your country, how much of the health financing is reliant on development partners? Because in Uganda, we see that one of the key obstacles we have is the role that the development partners play, because the health system is heavily reliant on foreign donors. So you have people like the World Bank, you have other countries like the UK, but also there is private philanthropies, and we see that many of them do play a big role in facilitating policy incoherence, but also promoting the growth of the private sector. And we see that for there to be some progress towards UHC, there is need to balance the power between the donors and Uganda as the receiving state, because many times, many of them will come with different ideas on what they think the priorities should be. People have talked about domestic resource mobilization, they've talked about the sector-wide approach, but it is not helping. And I would want to understand, what you all think about their role, but also how you think we can reduce the power imbalance between the donors and the recipient states.
I'm going to take 2 or 3 questions, and then maybe we can, Robert. Yeah.
Thank you. I'm Robert Yates from Chatham House and the Elders. Really, I'd like to ask a question of Emmanuel. Some really thought-provoking stuff, and I liked a lot of what you were saying, but just a bit concerned that you felt that people are equating universal health coverage with an American model, because my sort of viewpoint, the whole point about UHC is that everyone knows that the US is pretty much the only high-income country not to have achieved UHC. I mean, it's sort of, their health system's almost sort of a laughing stock in UHC circles. And the very sort of systems that we're celebrating are Sri Lanka and sort of Brazil with the source. And I think the recognition that people are saying that you can only reach UHC through a publicly financed health system, and we're just seeing this very, very clearly now. Now, I'm not saying that there aren't the forces of darkness, emanating out of the US, trying to mislead governments, not least in Kenya and in India as well. But it's very much up to the UHC movement to sort of, give this a red card and say this is totally incompatible with UHC. And if we really promote the likes of the Cuban health system as being shining examples of UHC, that we can win that battle and sort of see these forces off.
Thanks. Can you just pass the mic down? I think there was someone right there. Yeah, please.
Hello, hi. I'm Beher. I'm working as an independent consultant for the Foreign Health Relations Department of the Ministry of Health of Egypt. And in my free time, and a lot of my time now, working on a startup campaign that aims at bringing citizens' voice on the political attention or the global attention on the UHC, specifically on the lead up to the high-level meeting on UHC. My question is specifically to Ms. Dasgupta, I don't know, and Ms. Ruth Prince. About the citizens' voice and how it is important to bring it. But my question is more about how effective it is to bring citizens' voice to global policy making arenas, and if there was any kind of successful example to this beyond the example of the famous HIV movement, and as well if you have any insights about how successfully we can collect citizens' voice beyond the civil society organizations. The classical one, I might be provocative here, but we've witnessed from the last presentation that civil society became very different than before. It often became funded by corporate interests, and so it is questionable when we say civil society is expressing the voice of commons or the voice of citizens, that it really is. So I'm sure your insights.
Yeah. We'll just take the last one here, and then I'll come back to the panel.
Hi, I'm Archana. I'm a student in international community health, and it's quite new to me. But we took a class in UHC, and we had to learn about India. So I have this doubt because I saw in the 2017 agenda that bringing about the other importance for kidney dialysis or bringing new things in the agenda. But the older ones were still like, it's not been done, or it was not. I don't understand, how do you prioritize the things? That was quite new. In many countries, when we are in the class, they said us that still a dialysis, to bring it in a UHC, they're still considering about it. But in India, we have around 1 million of people can take a free dialysis. So how do you prioritize that?
Okay. So please hold on to your questions. We'll take it back to the panel. So would you like to use this, Ramya? Would you like to start? Or whoever wants to start.
So in response to Salima's question about funding, I would say that in Sri Lanka, philanthropic funding, there's very little coming in, but the World Bank is a key player in terms of funding, but that funding goes through the Treasury as a loan, so it's not really a grant. And so the Ministry of Health has quite a lot to say about what's happening with that funding, but I've been studying like all the reports of the various health sector development projects, and you can see how the World Bank project reports don't really say much about the agenda, but it comes in the national health development policies. So you can see them going in parallel. So that's in response. Do you think I could really quickly respond
To Rob's question?
Yes,
Yeah,
because
please do.
I just feel that in terms of celebrating Sri Lanka, they're just riding on the successes of Sri Lanka, but the model that's being recommended is not at all the model in Sri Lanka. So I would say that it actually is a joke, the kind of model that is being recommended by the people who matter, and it looks more like the US model than the Sri Lanka model, I would say. Oh, and just one last thing I want to say in response to what you said. I still think Sri Lanka is way ahead of India in terms of healthcare. Just
No, you can speak. Yeah.
Thanks for the questions, and so I'll answer the question about the financing and the role of donors, and then about the civil society. I think those were the two that I could talk about. So in Kenya, there's a very high, I think it's something like 40%. Edwin, is that right? 40% of of financing for health comes from donors, and that's really substantial. And then out-of-pocket payments really, really high. In fact, the exact figures, it's about maybe 35% donors. Out-of-pocket payments extremely high, and then government financing, just kind of less than a third of that. So, and so it's similar to Uganda in that sense. But there's, of course, especially since 2008, a lot of discussion about, well, this is not sustainable. How do we raise money for health? They've just introduced, for example, a tax on mobile money transfers and banking transfers. So a lot of discussion about how to raise tax, but whether that's a kind of regressive or progressive tax is a good question. So there's a lot of discussion about how to create more sustainable financing. I think it's really it's a very good question about the role of donors, because if you look at actually all these initiatives going on, even when there seem to be very much the government initiatives, there's a lot of World Bank involvement, and I think the question of, it would be really, really important to kind of ask the question of, so how do all these different organizations and actors, what is their notion of the public good here in relation to UHC? Because it seems to be there's a very little, there's a lot of big difference in how you interpret what the public good would be. But what I sense in my review of all these documents is that there's a really kind of solidification of the public good as something that is pursued through private financing, the question of raising money through tax, which was raised by the keynote speakers, something really important, and in relation to civil society, civil citizens and their voices, the question from over there. The Kenyan public is very, kind of middle classes are very active critiques of the government, newspapers, social media, a lot of critique about the government. At the same time, there's a lot of talk about, well, this only goes as far as the social media. It doesn't actually translate into real activism or real movements for social change. I think the question of how far the middle classes are willing to pay for the poor is something that is crucial, and that it already happens in many African countries because middle classes have big extended families which are maybe village-based, and they often pay out of their own pockets for their healthcare. So they have an investment in the public healthcare system, even if they use the private healthcare system themselves. So this question of class solidarity is a really important one.
Thanks. Yeah, Cristiani.
Thank you for the questions. The first one about donors. International donors are not that important in Brazil, in Brazilian funding, in the funding of the health system. they are less than 0.2%, and it's not significant at all. And the World Bank was never so influential in Brazil. It tried to be, but it was not as much influential as it was in other Latin American countries or in African countries, you know. And one example is the HIV policy. They tried to say since the late 80s that you should not buy drugs, and we decided, no, we will buy drugs. We have a universal system that's important as well, from promotion to treatment, and we did so. And so it's mainly public financed health system and private internal money. Private funding is 52%, more or less. And the tax system is very regressive. We have a reasonable tax burden, but the tax system is very regressive, and no government was able to reform it properly, okay? So there's a huge political conflict. And about citizens' voice, the Brazilian health system, one of its principles is social participation. So we have participatory health councils at the 3 government levels, at the national level, at the state level, and at the municipal level. We have more than 5,000 municipalities. They have participatory health councils. They play an important role. Of course, some of them are more active than others, and it depends. It depends on the governments as well, if they are open to enforce this kind of social participation. But it's really important. We have also participatory conferences to design the future of the health system and to discuss the main directions. That's it. Thank you.
I'll briefly respond to the 2 comments. Archana, when we say prioritizing conditions, so we are reducing human beings basically to a set of diseases. And I think the Alma Ata vision was really comprehensive primary health care for all, rather than saying you will get treatment for kidney failure but not for breast cancer. So it was meant to be comprehensive, and I think we stick to that framework. So I wouldn't actually go with trying to prioritize one illness over another. And to the question of citizen voice in international fora, I feel international fora really are assemblies of sovereign governments. And in order to uphold the principle of sovereignty, because we do not like it when development partners interfere in the policy-making processes of our country, it's very important to keep on reinforcing state-citizen relations and ensure that it's within countries that citizens can put pressure on their governments. And I think coming into an international platform and then trying to, in some way, denigrate what your government has done really puts their backs up, and they become very anti-civil society advocacy or lobbying efforts, right? So this is what I've learned from my years of work. But I do agree with you about not having funded NGOs as the only voice of civil society, and which is why I feel that social movements and people's campaigns within the country need to be active in engaging with their governments and trying to shape the positions that their governments will take on international platforms. So that's my take on it. Okay, so it's actually 1 o'clock, and I don't know whether Antoine will permit me to take one last question or not at all. Just the one, because someone had their hand up in the corner there. Just the one, Okay, yeah. Yeah.
I'll just speak loudly. It's just a quick comment that won't make the next question. So I just wanted to point out that it's not just the USA that has a bad reputation in this. I think one of the most disappointing things is the UK, which has a public, what we would call a public system. But nevertheless, parts of that system actually open up private practices in developing countries, and to actually undermine the possibility of the same NHS kind of system in the US. And there's also many other countries that do that kind of thing. So I just want to point out that it's not just the US or the people from the US that are undermining the possibility of stuff. There's many countries that have one story domestically and a different story internationally, and we need to start thinking about it much more in that page. That was my point.
And I think that's the story of global health, and the dark forces are everywhere, Rob. With that, I think I'd like to congratulate our speakers. Let's give them a hand.